Okay, here we go. Okay, so let's show you this particular case because I think this one's what's happened to my screen. Something's happened to my screen. Oh, hold a second. I've got a little technical glitch here. Okay. Hopefully this will fix it in a second. Becky? Okay. Becky, can you hear me?
Can you hear me?
Yep, I can hear you. Okay. Okay, so we're going to go through your case just very quickly afterwards because your case is a really, really difficult case, I've got to tell you.
Okay, all right.
I mean, that's like your case, which we'll go through very quickly. Their case is orthodontist don't want to deal with.
Oh, okay, all right.
Okay, but we'll go through and explain why. Okay, but from a teaching point of view, let's look at this particular case. Okay, this is a case of Keith Doones that I went through with him a while ago. So, who's online at the moment? Becky, why don't you just describe his face for a second?
Okay. I think he's mesofacial, but almost bordering on brachyfacial.
Yep.
Yeah.
Yep.
What else is there? When I look at his profile, I can see that we're definitely a little bit. Well, the lips can really come out more.
Yep. He's got a little bit of a very deep submental fold.
He does, yes.
Okay. And probably of most concern is obviously the position of his upper left canine.
Yes, absolutely.
Okay. So let me show you. These are his X-rays, and I've just okay.
Yeah.
Okay. So his APG doesn't show anything of any great significance apart from the upper eights are present and the lower right eight is developing.
Yeah.
Cephalometrically, how would you describe his ceph by looking at that?
Well, I'm now thinking, just now I was saying, the lips should come out more, but really maybe it's the nose is very prominent. That's probably more the way to look at it, isn't it?
I would agree with you 100%.
Yeah. What else does it say? We've got a deep sort of bite.
Yep. So just go back to the basics for a second. What are the 4 things that we want to look at in a ceph?
The S&B.
Well, let's just go more high level for a second. Every time you look at a ceph, and you see all these numbers that everybody puts at you, and what are those numbers? What really, in essence, if you just distill it down, what are those numbers trying to show you?
We're looking at the relationship between the upper and lower incisors.
Yep. So we're looking at the position of the upper incisors, position of the lower incisors.
Yeah.
We're looking at the sagittal skeletal, whether they're a class 1, class 2, or class 3.
Yes.
And if so, what would be the cause of that? And we're looking at the skeletal vertical. Are they a brachyfacial, mesofacial, or dolichofacial patient? They're the 4 things that we basically look at. Every time we look at a ceph, that's all we're trying to figure out on the ceph.
Okay.
And we're trying to we want to use the ceph to confirm what we see clinically.
Okay. Yeah.
Okay. Because clinically is more important to me than what the ceph says. But if the ceph says something different, then we've got to go back and go, which is right? Was it my clinical assessment, or is the ceph correct?
Yeah.
And that's probably especially true when you're talking about the vertical. Sometimes you find the soft tissue can really mask, are they a dolichofacial or are they a brachyfacial patient?
Yeah.
Okay. and also the position of the upper and lower incisors. So here it says to me the upper incisors don't look too bad according to the.
No, they don't.
But once again, it depends on which tooth which tooth are we looking at in that ceph. You could have the laterals very proclined, the centrals very retroclined, and what you're picking up on the ceph is that lateral, not the centrals.
Yeah.
Because you tend to always pick up the one which is the most proclined tooth when you take the ceph. Okay? So they're the four things, because there's so much stuff that goes on with cephs, and people go out there and they try to baffle you, you know, with these numbers, and they don't really mean anything apart from it's a diagnostic tool. That's all it is.
Yeah.
Okay. So to me, that's probably, you know, I would say mesofacial.
Yes.
Yeah. It could be verging a bit brachyfacial. Upper incisors seem to be quite well positioned. Lower incisors are not too bad. So let's look at it. So let's look at it clinically now. Okay. So let's go down. So when we look at the upper arch, what do you see in the upper arch?
Well, there's absolutely no space for that 2-3 at the moment.
Yep.
And there's crowding.
Yep. So the 2-3 is obviously the main problem.
Yeah, that's right.
The 2-3 is the main.
Something's happening to that lateral incisor as well. Like, as in, I mean, I know that obviously the 2-3 is sitting there, but then that lateral is also really palatal as well.
Yep. To be honest, it's probably not as palatal as what you would expect when you look at it from the arch form point of view. You could expect that to be very palatally positioned.
Yeah.
And the root, you know, remember we talked once before about torques. So when you look at from the occlusal point of view, you want to see the same amount of palatal surface showing on each tooth.
That's right.
Obviously, on the lateral, you're seeing much more palatal surface than you are on the other teeth.
Yes. Yeah.
So that would already imply that lateral needs more labial root torque. The root has to come out more labally.
Yeah.
Okay. And that's so. And on the lower arch, we've got some mild crowding.
Yep.
Okay. So describe his occlusion.
Yep. So he is a class. Oh, okay. Yeah, he is a class 2.
Yep.
For molars, for canine relationship is class 1. Hang on. Sorry, no, it's not. It's his canine relationship is class 2.
So on the right side, okay, that canine should be back
behind the lower canine.
Okay, so he's a full class 2 on his right hand side, and on his left hand side.
Well, the left hand side is almost. Well, it is. It is pretty much class 2 as well.
100%. It's 100% class 2.
Yeah.
Okay. So remember, okay. So he's class 2, and his midline. What do you think's happened to his midline? And
it's been shifted.
Yeah.
To the left.
More, and you would expect that, wouldn't you? Because he's got a blocked out upper left canine. So you expect there's been some mesial drift of the posterior segments, but also the anterior segment has moved around as well. And we've now got a totally blocked out upper left canine.
Yeah.
Okay. So far, so good?
Yes.
Okay. Okay, I'm just going to... Okay, so Manita's asked, is there a midline shift as compared to the rough A? Well, the rough, you can sometimes use that mid-palatal, what we would call the mid-palatal rough A as a guide. But can you see? Yeah, you can see your frenum here. Your frenum will always be associated in between your central incisors. So if you've got a midline shift, you can see how that frenum's deviated as well. Okay, so you may want to use this part of the mid-palatal rough A as a guide, but the best guide is the philtrum of the upper lip. And unfortunately, I can't enlarge these photos because they're on a PDF. but the best guide to your midline is to use your filtrum of the upper lip. That is the best guide. And so that's why you want to sometimes take a close-up smiling photo so you can see exactly where the where the upper midline is, which midline is off, because that could be an important part to the treatment plan. Yeah. Okay, so here we are. We're a full class 2. Okay, so I want everybody to give an opinion as to what are the treatment options here. So let's talk about ideal. Let's talk about compromised treatment plans, because as you all know in clinical practice, hey, these people, not everybody wants the perfect result. I think sometimes, but let's talk about how would you get the perfect result, and what are compromised treatment plans. So Beck, what's your thought process?
Well, if you did an extraction just on the one side, that would be really quick to get that tooth down into position, but the bite's not going to be, on the left-hand side, the bite's going to be in a class 1. If you took out, say, the first premolar, on the right-hand side, it's still going to be class 2.
Okay, so you lose so which tooth would you take out on the left-hand side?
The first premolar, so the 2, 4.
Okay.
The other option is to, I don't know how, but somehow try and get it into a class 2, but then we've already lost the E-space and all that sort of stuff.
So, okay, so let's say you wanted a perfect result and you wanted a perfect, okay, let's back up for a second. So here we are, we've got so you're going to take out the upper left 4, okay, and you're going to move the canine down into a class 1.
Yes.
Okay.
Yeah.
And leave them with a class 2 molar, which is fine. Okay. Now, if you
could do that on the left-hand side too. Well, sorry, you could do that on the right-hand side too.
Take out the right 4.
Yeah.
Okay. So then you would retract the right-hand side into a class 1. Yeah. Okay. And you would move the canine down into a class 1 on the left-hand side, correct?
Yeah.
Okay. So, okay. Can you think of any simpler options for this patient? Because you've now got a lot of work bringing that canine down. Yeah. Now, your risk analysis, and we're going to go through a lot of this with you in Module 1, Beck, okay? Your risk is what's going to happen to your lateral. You can't even start to move the root of your lateral forwards here. It's going to get in the way of the canine.
Well, the other option is to take the lateral out and then just bring that 3 down. But then from an aesthetic point of view, it's weird.
Yeah, that's one option. What about even a more simple option?
Even simpler option.
Yeah.
Just no extractions, try and fit everything in.
No. That's not a simple option at all. Okay.
I'll just take out the 3. Yeah.
You've got a perfect. You've just about perfectly class 1.
Yeah.
Okay. And you end up making this canine, the premolar, look like a canine.
Mm-hmm.
And we actually did something very similar at our last module. So Philip, if I could just find Philip's answer for a second. One sec, I'm in the wrong area. Philip, you are 100% right. Okay, because Philip suggested that you take out the 2, 3. Okay, take out the 1, 4, and we just move the teeth back. So we've basically got, in essence, like a unilateral extraction approach. Yeah. Because if we take out the 4 here, so let's say you went with that approach, okay? And I'll be honest, most orthodontists would do that. They'd take out the 2 upper 4s because there's this whole mentality that people say the canine is the most important tooth in the mouth, okay? But why? The most important tooth really to get canine guidance. So can you get guidance off your premolar? If we move your premolar forwards just a fraction, we're done.
Yeah.
we can wear some class 3 elastics on the left hand side, and then on the right side we basically go ahead and just close up all the spaces. But now, so from the point of view of what we need to talk about in later modules, okay, we need what we call a maximum anchorage on the right side. Okay, and by that I mean, you know how in Smilefast we've taught you go ahead and put power chain up a 6 to 6 and all that type of stuff?
Yeah.
Problem there is, as I do that, my molars are going to come forward significantly, aren't they?
Mm-hmm.
Okay, now I can only afford my molar to come forward by about 2 millimetres because I've got to get my canine all the way back into the embrasure between the lower canine and lower first premolar.
Yeah.
So I've got to hold back. I can't just go ahead and do what we call intra-arch mechanics, like as in within the arch, and just power chain, because there will be a reciprocal force that goes from the molar teeth forwards as well.
I'm sorry.
So I've got to make sure I use mechanics that will hold this back molar tooth.
Yeah.
Okay. And this is what this is where what we need to teach you, and that's what we're going to go through with these other guys in module 6, where all the different ways that we can maximise our anchorage, and we're going to teach you all about tip back springs in conjunction with class 2 elastics. Now, these are the type of cases where in the old days you could use headgear to hold back the molars, and that's what people did. So they would use their headgear to hold back the molars, and then you could put the power chain on, do all that, and the headgear was supposedly to counteract the posterior teeth moving forwards.
Yeah.
Okay.
Can I ask, Jeff, if you take out the upper teeth and then you're trying to obviously get everything straight, as you pull back those incisors, wouldn't the lower become an obstruction?
Absolutely, absolutely. So one of the so you have to do upper and lower treatment, and one of the principles that we talk about during your modules is you cannot resolve the overjet without fixing up the overbite first.
Okay.
So we have to. So there are 2 parts to this. One, to me, clinically, these upper central incisors are a little bit upright, even though the Seth might say they're fine. To me, clinically, they're a bit upright.
Yeah.
So I would want to get more torque on these upper central incisors. Okay, I would flare them out a little bit, so that way I've got a bit more overjet to retract the teeth back.
Okay.
Also, I need to open the bite. So if I don't open the bite as I retract the upper teeth, I'm going to hit those lower teeth. So one of the principles is you must open the bite before you start to retract teeth.
Yeah.
And we will go through all that with you in the different modules. So you're 100% correct. So we need to get the torque here. So for those guys who have done, you know, the other modules, okay. Philip, for you, this is the type of case where you go ahead, you level the line, so you go ahead and you put your double 14 night eyes in, you then go put your 20 squared in. I'm talking about the upper arch at the moment. You take out your upper left 3, take out your upper right 4, put your 20 double 14 night eye, 20 squared, 1925 night eye, and you would go to a 21 by 25 night eye, okay? And you leave that in for 8 to 12 weeks, get the torque, and then you drop back into your 1925 stainless steel wire, whether you use a little loop there with power chain or with a night eye coil spring, closing loop archway, it doesn't matter, but you drop back to your 1925. And what that does is it makes it all really level, the teeth will slide much better, and you've got more torque in your upper incisors, because whenever you take out teeth and you start to close the spaces, you will get some retraction of those teeth and you will lose torque on those incisors. And if you don't have the torque, you can't fix up the overjet. Does that make sense?
Yeah.
That's a bit advanced for you, Beck, only because you have the other module.
Going a little bit over my head.
Yeah, that's all right, because you're so far ahead of the game now, Beck, because you're starting to understand some principles. And once you get to these other modules, you're going to go, oh my God, this is really easy.
Okay, that's good.
So now that's really good. Now, what about the concept? What about the concept of? I'm just going to if you use a 21 by 25 with extraction space in the 1.4, wouldn't you lose anchorage on the 1.6? Yes, but I'm going to show you that you will lose some anchorage on the 1.6. But okay, but I'm going to show you what we're going to do with tip back springs to control the anchorage whilst we're doing all of that. Okay, but you could back that up with class 2 elastics as well. And you've got all these things to try and avoid losing any anchorage. Because what Philip's saying is when you get torque on your upper incisors, the upper incisors are flaring forwards, and now you've got a force system which is moving the entire upper arch forward slightly. So because when you've got the torque on the upper incisors, the upper posteriors want to come forwards a little bit as well. So you've got to always be cognizant of the anchorage requirements, which all it means is at each visit, you need to look at your molar relationship and your canine relationship. That's the key. Every visit when they come in, you look at that and say, what do I need to do to improve the canine relationship or to make sure that we don't lose any of our positioning? And that's all you've got to do. And then you decide, what are we going to do at that visit? Are we going to run elastics to back it up? Whatever it be. That's our decision making at each appointment.
Mm.
Okay, it really isn't that difficult because decisions are made within 1 minute chairside. Okay, once you understand the principles, you just go, hey, this is what I'm seeing. I'm going to now back it up with class 2 elastics. So it's very, very straightforward. Okay.
Would that be the case for all cases, including early treatment cases?
Early treatment, not so much. Okay, because you're not really doing extraction cases in early treatment.
Yeah.
So early treatment, not so much.
Okay. Yeah.
Okay. But when you start talking about full-on cases, yeah, absolutely.
Yeah.
Okay. Now, so anybody out there, Kim, can you hear me? I'll see if Kim wants to talk. Anybody would consider doing, I'm just going to unmute a few people if I can. Okay. Kim, are you there?
Yes, I am.
Okay. Well, what would be your approach to this case?
Yeah, I agree with that approach. I mean, the ideal approach would be expansion, but it would take a lot of time, a lot of effort for heroes. So extraction of the canine, I agree with that, yes.
Okay, but now, even if you expand it, how are you going to correct the class 2 buccal relationship and not end up with overjet? That's my question.
I don't know, Jeff. It's the ideal treatment that I'm not getting down on that path just yet.
Okay. Because the only other way, if you said I'm going to expand, well, we've got to get space. The only other possibility, and this is very heroic, and I wouldn't be doing it, okay, is to distalize. So to distalize your 7, distalize your 6 back into a class 1, distalize your 5, distalize your 4, okay? Same on.
Would you need a micro implant at the back if that's the case, or would you use headgear?
This would be very heroic with headgear, and you would need a micro implant or that type of stuff. But the problem that you've got is you've got the second molars fully erupted. So whenever you see the second molars fully erupted like that, your chance of success with any distalization process is minimal. Okay. Now this is where if you saw this patient when they were say 10 or 11 years of age, before the second molars had erupted, then you've got a much better chance of distalizing these buccal segments with a headgear, with a distal jet appliance, with whatever you want to use. Okay, you've now got a chance to distalize it. When they get to the stage when the permanent second molars are through, your chance of success is absolutely minimal, unfortunately. So this would have been a great case had you seen this patient at the age of 10 and you decided, you saw the amount of crowding, you saw the fact there was a lack of space for that upper left 3, and you go, okay, I'm going to try and distalize those. I'm going to try and distalize the buccal segments to get space. But if you do that, from a practice management point of view, you have to charge a lot extra for it because this is a lot more time. Okay? So you would tell the patient, you've got two options. I can try and be very heroic. I cannot guarantee it, but I can try and do this without taking out teeth and push teeth back. Or you're going to need teeth removed. And this is exactly what you're seeing, isn't it? Does that make sense?
Yes.
So yeah, expansion, great. How far are you going to expand the upper arch? Because, for example, and because this is another really interesting point with your expansion, the main issue is in your upper arch, correct?
Yes.
So you're going to expand your upper arch, and let's say you can expand and you can get all the teeth in. Okay, you've probably got 10, 12 millimeters of expansion, correct?
Mm-hmm.
Okay. What are you going to do on the lower arch? Because
tip the lower incisors out of it.
Yeah, but you've expanded the posteriors by 10 to 12 millimeters in the upper. You're going to cause a scissor bite. You have to expand the lowers as well. Because you've got a good occlusion. The expansion works very well when you've got a posterior crossbite. Because that's why you need to expand the upper more than the lower. So, Becky, this was what we were talking about with your case the other day.
Yeah.
So this is a case, you look at that and people start talking about expansion. Well, that's great. But what are you going to do on the lower arch? You're going to actually make the occlusion far worse. You're not going to correct the class 1. You're still going to leave them with an overjet. So that's why I keep saying to you guys that the most important thing you want to look for is the class 1 canine relationship, because that really is your diagnostic tool.
Yeah.
And once you start to say, hey, how can I get this into a class 1 canine, then the rest becomes easy. It's the jigsaw puzzle. And then you've just got to decide how you're going to do that. And so in this particular case, yes, it's a class 1 canine, but what we're going to do is we're going to take out the canine and we're going to use the premolar as the canine.
So we will have to shape the premolars, the palatal cups later.
Yep. So good point. So because what's going to happen is when you go into working side on your right hand side, you're going to end up with a interference on your palatal cusp of your premolar.
So you actually have to smooth it down.
You're going to need to reduce it a little bit. Yep. Only to the point of getting rid of the interference.
Yeah.
Okay. Now, if you really want to make this into a really, really good case, right? And we talked about this just at the last module. So let's say you want to make this, let's say this patient was an adult and they were really, really high level aesthetics. Okay. What makes the premolar? What makes this canine look so much better than the premolar on this side? When you look at it visually, what's the big difference between the two? Sorry?
Larger?
Larger. What else? So when you say larger, are you talking about
wider? Probably is the right word.
Sorry?
It's kind of wider and pointier.
It's wider, but it's also longer. And the gingival margin is different.
Exactly, the gingival margin.
Exactly. Okay. So what you can do if you really wanted to take this to the next level, okay, you would actually put your brackets on. You would put your bracket on your premolar more incisal, and what that's going to do is intrude your premolar. Okay. By intruding your premolar, it's going to bring the gingival margin up as well. When we extrude teeth, the gingival margin comes down. When we intrude teeth, the gingival margin goes up. And so then you basically intrude your tooth so you're at the level, so your premolar is now at the level of the canine, the gingival margin.
Yeah.
And you do a crown on that premolar to make it look like a canine. You've got the extra length there.
Yeah.
But that would be taking it to the next level.
Yes.
Okay, if that patient was very, very high end, a high end aesthetic patient.
Yeah.
But you can see, yeah, most people would look at that and go, we're going to take out the 2 upper first premolars or whatever it be. You've got a really simple approach by just taking out the upper canine here.
Mm. Yeah.
I'm trying to get you to think outside the box, but with the sound principles.
Yeah.
So Beck, let's finish off just with your case, because that case is a really, really difficult case. Okay, so I'm going to show you this case. The Becky is, if I can find it. I don't know what have I done. I had it here. Let me just grab it for a second.
Yeah. No, it's fine.
So you sent it to OrthoED. Any questions about that particular case? Because I think it's that was a really good case.
Mm. Yeah.
Okay. So Becky, you sent that to me. Here it is.
Monday night.
Yep. Okay. Okay. So this is such a difficult case. I honestly can't believe it. Okay. Here we go. Can everybody see this case now? 25-year-old male. He's got a very concave profile, but let's just concentrate on this. Okay. He's basically got a very high upper left canine with a deciduous canine still present. Okay.
Mm.
Right. He's got severely retroclined lower incisors. Okay. And most importantly, he's got an impacted upper right canine, fairly dolichofacial, class 3 skeletal tendency. Okay, so the problem that you've got here, first thing we've got to figure out is, okay, let's just talk about the lower arch just for a second. Okay, we have to open up his bite. His lower anterior teeth are going to move forwards. And the question is, how far forwards are they going to move? Okay, because he's actually a class 3 molar on the right side.
Yes.
Okay, so my first concern is, you go ahead, if we could even do all of this stuff, which you can, we go ahead and do the lower arch treatment, and the lower incisors are going to flare forwards even further, and we're probably going to end up with a class 3.
Yeah.
Just because of his class 3 molar relationship. That's our sign that he's going to be fairly class 3. I can't really see on this left buccal view, but
yeah, sorry, I forgot to take the other. I actually took it. I don't think it's saved. Yeah.
That's all right. That's all right. So that's one concern we've got. Okay. The other concern, and then so let's say Beck, he's a class 3, just for argument's sake.
Yeah.
Okay? Would you consider taking out a lower incisor?
Yeah.
Oh, really? Anybody else consider taking out a lower incisor here? What's the problem with taking out a lower incisor? This is why this case is so difficult, Beck.
Can it deepen the bite further?
It'll deepen the bite further.
Yeah.
But what else? Even worse. If I end up, let's say I take out this lower left central, okay? Because I'm trying to get room, okay? And there's space left over. There might be. And if I have to close up any spaces, what's going to happen? The lower teeth are going to actually retrocline even further. You're going to be fighting yourself all the time in these retroclined lower incisors.
Yeah. Okay.
So that's one part. Okay. The other part is it won't be a problem to bring down this upper left canine. That won't be a problem at all. Yeah, we take out the deciduous canine, and we bring back the upper left and we bring back this upper canine. That won't be a problem. Okay. Because in one way this is great, this left canine, because when I put the brackets on, it's what we call a consistent force system, because it's going to help to intrude these over-erupted upper anteriors. So that part's good. The part that's not good is your impacted canine. So your impacted canine here, which is on your upper right-hand side, and we don't have an occlusal view. We don't have an occlusal view.
I think there is one down when you go down.
Okay.
Yeah.
Okay. Philip's just asked a very important question. Oh, right. Okay, right down there. Okay. So we've got an impacted canine. Now we don't even know where that impacted canine is. Okay. Now my guess here is it could be labial.
Labial. Yeah.
Okay. And why do I think is it labial or palatal? No, it's probably palatal, because I think it's pushing on the root of that lateral right up the top there, and that's what's causing that lateral to retrocline. Yeah. So I think it's palatal, which makes it even worse. So firstly, we need to get extra space here. Okay, extra space to bring a canine in. Okay, as we bring that canine in, if we can, how old's this guy?
It's 25.
Yeah, so the longer an impacted canine is present, the greater the chance that tooth could be ankylosed.
Yeah.
So you might expose it, try to bring it in, and it won't go in. Now, to extract any teeth in the upper arch, it would be terrible in a class 3, because now we're going to move the upper teeth back further. So in a class 2 patient, like we had just previously, extraction of upper teeth is great. In a class 3 patient, that's the last thing you want to do.
Yeah.
Because you're going to pull the upper teeth back and make the class 3 worse. Does that make sense?
Yeah.
So, and to bring that canine in, you are going to be looking at a 3.5-year treatment plan, if you can even do it.
Okay. Yeah.
Okay. This is one, I'll be honest with you, you find the orthodontist you don't like, okay, and you refer it to, and I've got plenty of those names for you if you need them, okay? Okay? But this is a case. If I got this case, I would probably be saying to this patient, the most predictable way would be maybe some type of surgery, jaw surgery, because what you may end up doing is going, okay, I'm going to take out that upper canine. I might take out some teeth in the upper arch, make his overjet worse, as in a reverse overjet, okay, and then do the surgery.
Okay.
And that way I don't mind how far the lower anteriors move forwards. Now, Philip asked the question, which is an interesting question. How do you know if removing one size on the lower is sufficient to resolve the crowding, as opposed to removing 2 lower premolars? Firstly, Philip, the last thing you want to do in a case like this is to remove 2 lower premolars, I think, because your lower anteriors are already retroclined. So that would, if you remove 2 lower premolars, you would end up with more space, and that means there'll be more retraction of those teeth. So that's the last thing I think you want to do in a case like that. Now, if, on the other hand, if you had a class 3 and the anterior teeth were very proclined, in the Asian Bimax type situation, that's a different scenario. Then you might want to take out some lower premolars instead. But the question, how do you figure that out? That's when you do your digital setups. What we talked about in Module 5. And before I would even start this case, this is one of the cases that I would be doing a digital setup on without a doubt. And I would do 2 or 3 different scenarios for this patient to make a decision as to which is the best. How much space do I need to create to even get that upper right canine in? And is it feasible for me to do so? Because your advantage is you've got a little bit of rotation here, okay, on that premolar. That's one advantage. That'll give you 1 millimetre or 2 millimetres of space. But your disadvantage is you've got a rotation on your lateral, which is probably going to take up 1 or 2 millimetres of space. Then your other advantage here is you've got a little bit of space in your upper right central. Your disadvantage, though, is on your left-hand side, because you've got a deciduous canine and you've got to fit in your permanent canine. So you probably need an extra 3 or 4 millimetres of space just for this canine, an extra 3 or 4 millimetres of space just for that canine. So you're about 8 or 9 millimetres of space short, maybe not already. So you're going to have to find room to fit these teeth in.
Yeah.
So it is a really, it's a really difficult case with a really good chance when we start talking about risk management again that this canine may be ankylosed.
Mm.
So you might start to pull it across, and let's say you don't do it properly. You've got a great chance then of damaging the lateral incisor. As you pull that tooth down, that could be right up against the root of the lateral incisor.
Would the ankylosis be something that you can see on the CBCT? Not really, yeah. Until you really go and do it, that's when you see it.
Yeah, there are hints on the CBCT. There are hints on the CBCT, but the only way to definitively know is to expose that tooth and start to pull it in.
Mm.
Now, the oral surgeon, when he exposes that tooth, can try and immobilise it. And I've had this happen a couple of times where I've said to the oral surgeon, you go and expose it, and if you feel it's ankylosed clinically, then go ahead and remove it. Yeah. And you leave the decision with the oral surgeon. I personally don't like doing that, but I've had to do that twice.
Okay.
Because that's really the only way. And the other problem, and it's happened to me a few times, that you start to move the canine in these situations, and it moves beautifully, and then it stops. It actually ankyloses during treatment.
Oh wow!
And I'll show you a case in module 1 of that of how that happened.
So Jeff, can I ask a question?
Yeah.
Now I'm scanning through all the names in my head in terms of orthodontists to refer to.
Yeah.
And you were talking about digital setup.
Yeah.
There's only one orthodontist in town that I know is very familiar with digital setup, to my understanding. And I'm just thinking, but the problem with her is she purely works with aligners. Is that going to be? But she claims that she can do any case. So I'm thinking, would this be something potentially to?
If she can do,
and I would say out of everyone, just from all the treatment planning I've seen, she's probably been the most sound.
Okay.
Yeah.
It'll be interesting, but I will just about guarantee you cannot, well, you cannot treat an impacted canine fully with aligner therapy, but you might be able to do some combination treatment. Yeah. So because like they might expose the canine, run it, put a bracket on the canine, bring it down. I would love to see this case treated with aligners on the basis of I don't believe it can be done.
Okay.
Okay, if they can do this case with aligners, I take my hat off to them.
So maybe before I do a referral, maybe just have a chat to the person first and see what they think.
Yeah, what I would do, because before you muck the patient around, okay, I would send them all the photos, send them the X-rays, and just have a chat to them first.
Yeah.
And then if they really believe they can do it, oh my God, tell them that they have to document this case and send you photos every 3 months. Seriously. Yeah. Seriously. I think you've got to make these orthodontists accountable. Okay? Well, it's no different to you send them off to an endodontist and they're going to give you a periapical at the end of their treatment, aren't they?
Yes, that's right.
Yeah, that's standard. And that's what these people should be. In ortho, it can't be just at the end because you've got to see what's happening during the treatment.
Yeah. All right.
So it's an interesting case. When I saw this last night, I'm going, oh my God, how am I going to discuss this with everybody? Because this is a case which is which is one that I wouldn't want you to do, honestly, Beck.
No, that's fine. Thank you for that. I prefer to know that up front then.
Oh, absolutely. Absolutely. But a digital setup would be really good to and that way you can have a look at it. But a digital setup, and we just did this in module 5 just last week. Anybody can make a pretty picture out of a digital setup.
Yes.
Okay. The question then becomes, how realistic is that? Can we achieve it?
Yeah.
Okay.
All right.
But I'll be very,
but I'm really glad that we went through this case. Thank you.
Yeah, so am I. I'm glad we went through the other one because I think the other one was a great learning exercise. And this one is also a great learning exercise, but in a different way.
Yes, it's to learn to say no.
Well, it is, because I tell you what, I bet you the orthodontist you refer it to, if they say yes, they're going to do it, because they've made a statement saying they can do everything, right? So now they've got to back it up.
Yeah.
And I reckon they're going to regret this. But I'd love to keep updated on this case.
Yeah, I will. I definitely will. Yeah, I'll update you.
Thanks, guys. I hope you got something out of today, and we shall actually. I'm not too sure about next week because I've got to fly out. We've got to fly out to Brisbane. So
fortnight's time.
Yeah.
Beautiful.
Yeah. We'll try. We'll still try and do next week if we can. Okay.
All right.
Okay. See you guys. Have a great day, and thanks for your time.
Thank you. Bye.
See you later.